and a sense of ownership of the government programs. Government of Andhra Pradesh considered that the APHRD Institute should emerge as a national institution of excellence, duly focusing on modern administrative and management techniques as also the right mix of service and self-sufficiency. Well-equipped hostel facilities is available at all the centers of APHRDI. AC residential accommodation is available for all the resource persons and the participants at all the centers of APHRDI. APHRDI is one of few administrative training institutions in the country to have the National Knowledge Network facility. This enabled us to establish instantaneous video link for effective interactive sessions with about 1600 national institutions all over the country. APHRDI has so far facilitated 8 international presentations from US, Estonia, China, Sri Lanka, and England. APHRDI has completed 746 programs since its inception and trained nearly more than 70,000 employees. APHRDI has so far completed 260 online knowledge sharing sessions from 22nd April 2020 onwards, with the participation of nearly 1 lakh employees. APHRDI has conducted First Bell program of Government of Kerala initiative and has received a record views of more than 1 lakh in YouTube. A number of training programs of the APHRDI are being supported by Department of Personnel and Training, Government of India. The institute has so far facilitated training and state exposure for 81 officers of Central Secretariat from Government of India in the last 4 years. This is done in 6 batches of training. Senior functionaries of Indian Foreign Service have also been attached to APHRDI for their state exposure. Training programs of been conducted also facilitated the conduct of state attachment of civil service officers from Haryana as part of Bharat Darshan. Government of India have initiated a unique program called Ek Bharat Shrestha Bharat for facilitating officers from 2 states to spend considerable time in both the states. AP has paid with Punjab in this regard during 2019-20. APHRDI has completed capacity building training on Titli Cyclone project in collaboration with AP State Disaster Management Authority and UNDP. APHRDI has also conducted post-disaster need assessment study of the flooding in Godavari River with particular reference to East Godavari district. APHRDI has also completed a unique 15-day induction training program for visually impaired and deaf and dumb categories of employees belonging to different departments. This is supported by Department of Personnel and Training, Government of India. APHRDI has completed direct trainer skill training to 424 identified resource persons and coordinators for the Animal Husbandry Department. A total of 2,500 distinguished resource persons from different parts of the country have made presentations at APHRDI. All these details are available at our website www.aphrdi.ap.gov.in. APHRDI has evolved the practice of providing internship to college students in different streams. For the year 2020-2021, BITS Pilani Rajasthan Hyderabad campus has deputed 30 students to APHRDI under practical school program. This has concluded. Center for Sustainable Development Goals established in APHRDI in association with UNICEF Hyderabad Field Office in the year 2018. In the current year, CSVG Center is pursuing disaster risk reduction activities under goal number 11 with support from UNICEF. This is in addition to promoting all other sustainable development goals through appropriate capacity building efforts. UNICEF has sanctioned one more project called Child-Friendly Local Governance by capacity building and strengthening of the Gram Panchayats volunteers and all other local stakeholders towards child-friendly local governance and building the resilience of local governance institutions to help mitigate the adverse impacts of emergencies. As part of this project, APHRDI has completed training of district level officials of 5 major departments and also mandal level and GP level programs. Ministerial Hygiene Management Working Committee has been constituted by APHRDI with technical support from UNICEF. This committee is unique in South India and has members from all the major line departments. As per the recommendations of the Ministerial Hygiene Management Working Committee, Srimati Anuradha Madam, Principal Secretary, Women Development Child Welfare, has issued a GO notifying working committee in Andhra Pradesh. This GO enables APHRDA with support from UNICEF Hyderabad field office with all line departments of AP for effective implementation of various programs, policies and guidelines related to MHM towards creating a safe, supportive and healthy environment for women and adolescent girls to maintain MHM with dignity and privacy. Today's session is planned in two sessions, one by Dr. Iswar Reddy Garu on regulatory approval process of COVID vaccine, and second session by Dr. Juni Sebastian, clinical pharmacist, JSS College of Pharmacy on vaccine experiences of JSS in clinical trials. It's my great honor and pleasure to introduce Dr. Iswar Reddy Garu, first speaker of today's program. Dr. Iswar Reddy Garu is currently holding the post of Joint Drug Controller General for about 1.5 years during February 2018 to August 2019. Dr. Reddy was born in 1969 in the state of Andhra Pradesh. He completed his master's degree in pharmacy from College of Pharmaceutical Sciences, Manipal in 1994 and PhD from JNTU, Hyderabad in the year 2009. Dr. Reddy started his career in 1998 as drug inspector at Central Drugs Standard Control Organization, Bombay. He was promoted as Assistant Drugs Controller of India in 2019 and appointed as Deputy Drugs Controller in 2012. In 2014, he was appointed as Joint Drugs Controller. In February 2018, he joined as the youngest Drugs Controller General who has worked for all the portions of the hierarchies. Dr. Reddy has participated in many national and international seminars on various areas of drugs regulations. He was awarded with Best Drugs Inspector Award in 2005, Best Drugs Controller Officer Award in 2016, and Distinguished Alumni Award. Dr. Reddy was recently honored with Sri B.V. Patel Education Trust Award given in appreciation of valuable contribution in the field of pharmaceutical sciences. Now I request Dr. Iswar Reddy Garu kindly take the session, sir.
Yeah, thank you, madam, for the nice introduction. And let me first thank Director Andhra Pradesh Human Resource Development Institute and also their entire administrative staff for giving me opportunity to share the regulatory views on the approval process of the COVID vaccine. I'm going to share my presentation.
Yes, sir. Ravindra Garu?
Yeah, are you able to see?
Yes, sir, visible,
Yes.
sir.
Is it visible?
Yeah, it is visible, Mr. Reddy.
Yeah. So
Okay.
thank you very much. I think first, once again, I welcome you all, and I'm very happy to hear about the institute, about their contribution, and I think the thousands of officers and students got benefited from this institute on various training programs. I'm very happy to hear. I hope my organization also may need your support and your assistance for conducting some various program. I'm sure we can also have some collaboration how we can further strengthen the training program among the drug regulators in India. I think I am happy to see there are more than 1,000 participants in this today's program. But I don't know their backgrounds, who are the participants, and I think thinking that this program is mainly I'm going to make for the one layman who is not aware about the what are the vaccines and what are the regulations. So I made a simple presentation, try to make understand everybody how drug regulator will approve the vaccine and what are the regulatory requirements. And, as you know, in the media, everybody is too eager about understand so many issues. One is about the efficacy of the vaccine, second about the adverse events, and everybody is eager to understand who are the major manufacturers doing clinical trials, and what are the clinical trials, and how the safety efficacy will be seen by the regulator. I think there are so many questions among in the minds of the public, and let me in the given 1 hour time, let me try to percolate the information whatever the best possible. So in my presentation, I'm going to briefly give about my regulations, that is the Drugs and Cosmetic Act and rules, and just I will give idea about the vaccine development process involved in that, and how the vaccine efficacy is determined, and also how the safety of the subject. Here, subject means the persons who is involved in the clinical trial, who is taking the vaccine, how his well-being and his rights have been protected during the clinical trial, and also what are the current status of various vaccines at present in my organization for the approval, and finally about the conclusion. So just as the drugs and cosmetic the act, the drugs falls under the concurrent list of the constitution. So that's why both central government and the state government, they are responsible for enforcing the drugs and cosmetic act. Because of this, drugs comes under the concurrent list of the constitution. This act is applicable to the whole of India. So, who are the implementing authorities of the Drugs and Cosmetic Act? On behalf of the central government, the Central Drugs and Standard Control Organization, that is the CDSCO, is the regulatory body to implement the various provisions on behalf of the central government. And on behalf of the state government, the concerned state drug regulators are responsible for the implementation of the various provisions. First of all, if you see what is the objective of the Drugs and Cosmetic Act, the major objective of the Drugs and Cosmetic Act is to ensure safety, efficacy, and quality of drugs. Here, drugs means the drug includes biologicals. Biologicals include vaccines and other products. Drugs include medical devices. We also regulate the cosmetics. We also regulate the veterinary drugs. So that's why the drug controller is responsible to ensure safety, efficacy, and quality of drugs, that is including vaccines. So that's why the drug approvals are taking place from the drug regulators because of the mandate given under the Drugs and Cosmetic Act to the drug regulators. So just I will use brief idea about what are the central government responsibilities under the Act, and what are the specific state government responsibilities assigned under the Drugs and Cosmetic Act and rules. If you see the major responsibilities of the central government through CDSO, what we are implementing is first new drug approvals. Here drug, as I said, including vaccines, means before introducing any drug or vaccine or medical device in the Indian market, first the drug has to be approved by the central government, because of central government will ensure the safety, efficacy, and quality of the drug. This is the most important thing. But central government is not the licensing authority for grant of manufacturing licenses. Only approval is required. Here it is not a license. So based upon the approval granted by the central government, that manufacturer will go to the concerned state regulators, where state regulator will grant the manufacturing license. Second most important responsibility of central government is we regulate import of drugs and medical device. Any drug, medical device, cosmetic are to be imported into India. First, that manufacturing site and the product has to be registered with the central government. Without registration, no drug, including vaccine. See, for example, tomorrow, in case the Pfizer vaccine is going to be approved in India, so the Pfizer has to import this vaccine from the USA or European Union. So first, the Pfizer has to register their manufacturing site product with the central government. Then only they can import into India. The central government is also responsible for conduct of the regulation of the clinical trials. No person can initiate the clinical trial without approval from the central government. In fact, even vaccine clinical trials, whatever going on in India, without prior permission from the central government, no person should initiate the clinical trials. Another major responsibility of the central government is let down the standards of drugs, including vaccines. See, for example, tomorrow COVID vaccine, central government is going to be approved. What should be the standards of that vaccine? So the standards also will be laid down by the central government for all the drugs, cosmetics, and medical devices. And administratively, if any amendments to the act and rules for the Drugs and Cosmetic Act is central government responsibility. And another major responsibility is the pharmacovigilance. After approval of any drug or a vaccine, the monitoring of any serious adverse events or any adverse event related with the drugs are monitored by the central government. And the major state government responsibilities are they are the responsible for grant of license for manufacture, sale, and distribution. They also monitor the quality of drugs and cosmetics moving in their state by drawing the sample by the concerned drug inspectors and sent to their concerned laboratories for evaluating the quality. They also involved in the investigations and prosecution if any violations are there under the Drugs and Cosmetic Act. So yes, I have one slide on this organization, that is the Central Drug Standard Control Organization. This is actually headed by the Drugs Controller General of India. We have a headquarters at New Delhi. Under the headquarters, we have various divisions which are operating under the Drugs Control General of India and CDSCO. We have new drug division, looks after all the new drugs. We have a separate division to monitor the clinical trials. We have a separate division for imports and a dedicated division for biologicals. The vaccines comes under the biologicals. The vaccine, COVID vaccine, all are looked after by the biological division. Similarly, we have separate division for medical devices, division for export, quality control, pharmacovigilance, and legal affairs. In addition to that, we also have a 6 zonal offices located across India and 6 sub-zonal offices also. Mainly, they are the responsible for the field job. They will conduct the audit of the manufacturing facilities. And we have port offices where any import of drug to be made into India, that has to be come only from the notified ports. So the CDSU officers are posted at port offices. They will draw the sample before release of the particular drug into the market, and they will evaluate the quality randomly by drawing the samples. And also they will check whether they are holding the import license as per the provisions of Drugs and Cosmetic Act or rule. We also have 7 laboratories, central government laboratories, where we evaluate the quality of the drugs, including vaccines. We have a central drug laboratory at Kasoli, where these COVID vaccines are going to be tested. We have developed a complete facilities for evaluating or testing of the COVID vaccine. And this is actually strength. This slide talks about the strength of India. In fact, if you see, every country is looking at India because of we have a huge manufacturers in India, and we have a huge manufacturing capacities. You may be knowing recently almost 100 different ambassadors of various countries. They have visited Hyderabad to visit some of the vaccine manufacturers. Because every country is looking at India, because we only is able to manufacture such a quantities and able to supply to the all the needy people. And in fact, in India, we have a 21 human vaccine manufacturers, out of which 9 manufacturers are WHO pre-qualified. Here, WHO pre-qualified means whenever any international agencies procure a vaccine, like UNICEF or even WHO for any other organization, first the WHO Geneva office, they will inspect the Indian companies and they will assess as per the WHO standards. Once they comply with the WHO standards, then only that company can able to supply to the international agencies like UNICEF. So like we have 9 companies, total 26 different vaccines have been approved by the WHO for supply to the international agencies. In fact, in India, we are manufacturing 44 different types of vaccines, whether it is a polio, MMR, or DPT, or there's so many, there are 44 different vaccines we are manufacturing. And also, I'm happy to inform you, we are exporting to more than 170 countries our vaccines. In fact, every third child in the globe is receiving our vaccine. So maybe public may have some, doubt that what is our capacity of vaccine manufacturing. So I think at present, whatever we estimated the capacities of COVID vaccine, I'm talking about specific to the COVID vaccine. So our companies at present we have 3 Indian companies are in very advanced stage, and the other companies they are in the pipeline. So these companies are able to produce 2 billion doses per annum. So this is the huge capacities what we have in India. This is the great strength of India in the vaccine manufacturing. Coming to the today's topic, COVID vaccine development. I think for the benefit of the all the participants, those who don't know about what is a vaccine actually. You see, actually, technically, a vaccine is a biological preparation. Mainly, this improves the immunity to a particular disease. So actually, these vaccines will provide immunity against a particular disease. In fact, a vaccine, mainly this vaccine contains an organism and is often made from weakened or killed forms of the microbe. For example, in case of COVID SARS-CoV-19 virus, we have a spike protein. Everybody, you must have seen spike on the surface of the virus. So the spike protein mainly we manufacture spike protein with chemically or otherwise through recombinant technology, and this spike protein is given in the form of a vaccine. So that resembles the real spike protein of the COVID virus. So that act as a antigen that will produce the antibodies in human beings. In fact, this antigen stimulates the body immune system to recognize the agent as a foreign material and destroy it and remember it so that immune system can more easily recognize and destroy any of these microorganisms that it later encounters. Mainly, the very important point of this antigen is that our B cells in our body recognize or remember this particular antigen for the particular virus, and even in future, for example, if you see polio vaccine, we will take at the after birth, and that vaccine, our cells is able to recognize any time in our lifetime, even after 10 years, 20 years, 30 years, even if that particular polio virus will attack us, our body is able to produce antibody. That is called the memory. In our body, we have a memory cells. So once this vaccine is given, but this memory is vary from the vaccine to vaccine. Our body will remember for some vaccines years together, like measles. We have 50, 60 years of memory. But so for influenza, so influenza maybe need to be given every year or at least once in a year to maintain the antibodies. But for this COVID vaccine, once it is given, how many days it will give protection, these still studies are going on. So at present, we don't know whether this will be effective for 6 or 1 year or 2 years or 3 years. This is yet to be scientifically proven through extended clinical trials. If you see how this vaccine works, so mainly this, as I said, this vaccine produces the immunity. So this will induce the active immunity, that is immunity and immunogenic memory similar to natural infection, but without risk of a disease. So this is the most important thing. In fact, we will get antibodies through two sources. One is through the virus itself. For example, now in India, there's more than almost 1 crore positive cases still now. So these people will have antibodies, mostly by and large. Most of the people may have the natural antibodies because of the virus already. It was there in their body. So those who are don't till now not affected with this virus, they can also produce antibodies through the vaccine. So that's why these antibodies are produced either through active immunity or otherwise through your passive process. And immunological memory allows the rapid recognition and response to infection, and that prevents or modify the effects of the disease. What should be the ideal characteristics of a COVID vaccine? So generally, for every particular, if you take any, for example, your mobile. So we should we expect every mobile should have some ideal properties. What should be the general ideal properties? So for vaccines also, the most important ideal property is the vaccine should be 100% safe without any reactogenicity. Reactogenicity means any symptoms after administration like fever, cough, cold, or any vomiting. So vaccine should be 100% safe. It should not have any reactogenicity, and it is expected vaccine should be 100% efficacious. But these are the ideal situations. But none of the vaccine or none of the drug is 100% safe and are 100% efficacious. But based upon the risk and benefit of that particular product, as a drug regulatory authority, we will approve based upon the need of that particular drug or a vaccine to the public. And also the dose regimen. It is advisable. Generally, ideal vaccine should be with a single dose. But there are many vaccines, it will be multiple dose. For example, COVID vaccine, most of the manufacturers, they claim it is a 2-dose vaccine. But ideally, vaccine should have been a single dose. And also it should be a thermal stability. You must have come across in the media, one of the major issue of this COVID vaccine of the particular company like Pfizer, their storage condition is minus 70 degrees centigrade. So countries like India, it will be very difficult to transport, to distribute this vaccine at minus 70 degrees centigrade, and also to store such type of vaccines in our different hospitals or different places where this vaccine is required. But ideally, this vaccine, if it is a good vaccine, means that should be stable at the room temperature. There are some manufacturers are developing such vaccines also, which will stable at room temperature. And another important factor is the cost. This vaccine should be, affordable to all the needy population. If the vaccine will be available tomorrow, developed at a very high cost, which may not be able to affordable, that it may not be ideal vaccine. So ideally, that vaccine should be cost effective and also ease in administration. So generally, this vaccine, especially COVID vaccine, it is injectable form. That means we need another person's assistance, like a nurse or a doctor, to administer this vaccine. Otherwise, if the vaccine could have been any oral route, or otherwise could have been a nasal route, so even without any much other stakeholder support, the vaccine can be administered. And another important property of vaccine should be lifelong immunity. As I said, some of the vaccines, if you are administered at the child stage, that will protect the body till many years, maybe 50, 60 years. But this COVID vaccine, we need to see how many years it will provide the immunity. And finally, if the vaccine is able to administer for all population, that means all ages, whether it is a children or a pregnant woman or it is any comorbid person, all categories of people, that vaccine should able to be given. So these are the general ideal characteristics of the vaccine, but generally none of the vaccine will have all these properties. And another important, this slide talks about the what are the different types of technologies that have been developed and that vaccines are at present or the clinical stage. And I have taken mainly with respect to the Indian perspective. So here mainly in India, 4 different types of vaccines are developing. One is the DNA vaccine. I will explain you later how the DNA vaccine works. And the second is the messenger RNA vaccine. Third is the recombinant DNA vaccine. And fourth is the inactivated whole cell viron. This inactivated whole cell viron is a very old age platform. Many vaccines have been developed in inactivated whole cell viron. The live virus like COVID virus, live virus, they will take and they will multiply, they will propagate in the media, and then they will inactivate that virus and they will isolate and purify that virus, and that inactivated virus given in the form of injection to the patient, to the healthy people as a vaccine. So this is a well established, but generally inactivated whole cell viron is more safe, but efficacy point of view, it may not be up to the efficacy of messenger RNA vaccine. And I'm also happy to inform all of you the DNA vaccine and messenger RNA vaccines are not yet approved globally anywhere for any disease. This is the first time this technique, this platform has been developed. And though this messenger RNA DNA vaccine research is going on last 20 years, but till now, no vaccine has been approved for the any particular disease. However, the messenger RNA vaccine recently US FDA, MHRA, that is the UK, Canada, Singapore, these countries, they have granted emergency authorization. So emergency authorization is different with the approval. Emergency authorization is nothing but it is a tentative approval. So tomorrow, based upon the further data available, that final action will be taken, the final decision will be taken by the drug regulator. Recombinant DNA vaccines, already this technique is available in India and the globally. Some other vaccines like hepatitis B and other vaccines also produced based upon the rDNA technology. So as I said, these vaccines will produce the immunity. So this immunity, if you see, immunity is a body's ability to resist or eliminate potentially harmful foreign materials or abnormal cells. In fact, God has given us such a wonderful body. Our body is able to produce various types of chemicals, proteins, enzymes, which we don't know. Thousands it will produce based upon what any virus or a bacteria or any pollution or a germ or a parasite, if anything enter into the body, our body has such a excellent self-defense mechanism. It will take care about all these foreign materials. Even if you see when your body is cut and your skin is cut with any sharp particles, but many times naturally it will heal. So our body has such a beautiful immunogenic character. Most of our disease things are controlled by our body, but provided if you maintain that immunity. If you don't take proper food and proper healthy diet and if you are not follow proper exercise anything, then our natural immunity will go down. So always better we should maintain the natural immunity such that tomorrow but if you see in India our recovery rate is so high. This is mainly because of our immunity we have, because of our natural immunity. The people, those who have got suffered mainly because of either comorbidity or because of the immunological issues. And if you see the typical immune response, in fact, just it is for your information, we have if you innate immunity, what we call, and also acquired immunity. Innate immunity, whenever any invading microbe comes, we have external defense. For example, our skin itself will give protection from many different types of organisms or other things. It won't allow to enter into the body. Second, mucous membrane, either it is a nasal or any route, we have a mucus that will prevent entry of that. Like secretions, even if the secretions is tears, tears itself is a beautiful protection it will give to the body. It won't allow the entry of any organisms inside the body. Internal defense mechanism, we have a phagocytic cells, we have antimicrobial proteins, we have a inflammatory response giving against a particular thing, we have natural killer cells. These all will have the internal defense mechanism, and we also have a humoral response through antibodies we will get. I think this is a little technical, but just for your understanding I am giving what different types of immune response we will get. Another is the cell-mediated response. Generally, it's cytotoxic and the lymphocytes. This slide talks about how the actually immunity, if you see whether DNA vaccine or RNA vaccine or otherwise it is a rDNA, recombinant DNA technology. So the DNA present in the virus, that is the COVID SARS virus, they will isolate that and they will purify and they will really decode which DNA is responsible for producing the spike protein. So that particular, because of the China has done complete decoding of this gene and they have completely come up with the codes and they identified that particular DNA. So they develop this DNA, and some vaccines they give as it is DNA to the humans. In the body, the DNA will DNA like a hardware. It will have a software inside body called messenger. Messenger RNA act as a software. It will give direction to our healthy cells in the body. And because based upon the messenger RNA's direction, our healthy cells in the body will produce proteins. Generally, these proteins resembles like a spike protein. It acts as an antigen, and that will lead to production of antibodies in the body. So whether it is a DNA vaccine directly, or whether it is a messenger RNA, or the vaccine may be directly having a protein, whatever different types, but end of the day, that will produce the spike protein or otherwise proteins that will lead to the production of the antibodies in healthy subjects. This slide mainly talks about how the vaccine is developed. So this is the most important slide in the presentation. So generally, before testing the vaccine on healthy human beings, first the vaccine is tested on animals. Generally, it is called as a preclinical studies. They identify the platform, whether they want complete whole cell virus platform or DNA platform or messenger RNA, what platform they want. So they will they develop that platform, and that particular vaccine which was developed is first tested on animals for two reasons. One is for the toxicity. So they will do the subacute toxicity, long-term toxicity. This is the most important to ensure the safety of the vaccine. Second, they had to do the animal pharmacological studies, how the vaccine is behavior in the animals, including pharmacokinetics. And very important in the preclinical studies is they had to develop a proof of concept. So as a part of the proof of concept, first they will give vaccine to the animal, and that animal is exposed to the COVID virus, and they will see that whether that animal is that vaccine taken animal is protected from that COVID symptoms or not. So they had to develop a proof of concept in the animals. So that means in the preclinical first stage, they will do the animal studies for that with respect to the safety and also the proof of concept. And once if that data, they will submit to the regulators. And if the data is satisfactory, then only we will allow them to do phase 1 by 2 in case of a COVID vaccine. COVID vaccine, you must have heard about the one terminology called adaptive trials. Adaptive trials means it is not like a sequence thing. So first you complete one, then you should go to the phase 2, then you go to phase 3. So it is not like a sequence. Adaptive means you can combine the trials because of we need this vaccine immediately at the earliest with sufficient safety and efficacy. So that's why we follow the concept of adaptive trials. That means doing things simultaneously, not in a one by one. So once the phase 1 by 2 data is satisfactory, then we will grant the next phase 2 by 3. And if the data is satisfactory, finally we will give the permission or the licensor. After permission licensor also, we will go for the post licensor vigilance, generally what we called as the pharmacovigilance program. But in our CDSCO, because of the COVID very pandemic situation, we have developed an accelerated, dedicated system in our organization. That's why if you see overlapping of process, we have permitted in this, and we are doing the rolling reviews. Rolling reviews means we are not waiting till completion of the study and submit the data. As and when whatever the data they are submitting by prepared by the company developer, they will submit to the regulator. So regulator simultaneously they will review the dossier accordingly. So that's why we have started the rolling review also. And we have created a complete enabling environment. That means we have provided facilities for the pre-submission meeting. That means even before submission of the application, the applicant can have a dialogue discussion with the regulator. What are the regulator's expectation? and what are the regulatory pathways, and what are the regulatory documents required for getting the various permissions and approvals to approve the COVID vaccine. And another very important thing is in the clinical trials, recruitment of subject is also very rapid, because otherwise it will take long time to develop any vaccine. It will take 8 to 9 years, but that we brought to the 8 to 9 months. So until unless the research, accelerated review, accelerated approvals, and complete collaborative work of the regulator, industry, and the experts, then only we are able to make this vaccine going to be available at the earliest. So as I said, the first we will they had to conduct the phase 1 clinical trial. And after conducting phase 1 clinical trial, they will submit the data to the regulators. We will review the data. If the data is satisfactory, then we will allow them to do phase 2 clinical trials. Similarly, after completion of phase 2, they will submit the data of phase 2 to the regulator. And again, regulator will review the data. If the data is satisfactory, then again permission is given to the phase 3. And once the phase 3 data is satisfactory, then only permission is granted marketing of that particular product in India. This slide talks about actually what we do in the phase 1, what we do in the phase 2 and phase 3. Because of you may be having some, you want to eager to know phase 1 means what actually happens in the phase 1. So one strength of these vaccines is vaccines are tested on the healthy subjects. It is not like a drugs. For the development of any new drug, generally drugs are tested on patients. See, for example, if any drug is developing for cancer, then the drug is tested on cancer patients. But whereas in these vaccines, the vaccines are tested on all healthy subjects. So that's why we should be very, very cautious about the safety, well-being, and rights of all the clinical trial participants. So the people, those who are participating in the clinical trials, it is the regulator's responsibility to see their safety as well as their well-being. So the phase 1 means, as I said before, phase 1 preclinical trials they will do on animals. Once that animal data is satisfactory, then we allow to use first in man trial. So phase 1 means it is a first in human trial. So generally we will allow to do on a limited population. So say for example around 20 to 80, depends upon the type of the vaccine. And what do we find out from this phase 1 is what reactions occur after vaccination. So that's why these are very closely monitored phase 1. After the vaccination, that person is directed to be in the hospital for some time to observe any reactogenicity. That means any fever, cough, or vomitings, or any redness of the skin, or any allergy. So they will observe that. Second main objective of the phase 1 is whether safety, whether the vaccine is safe or not. This will be established through the phase 1. And also, does it give rise to required immune response? So sometimes they will also draw the blood samples from that particular subject and see whether any antibodies have been developed. That is called the immunogenicity. And in the phase 1, also the another main objective is dose ranging. That means how much vaccine that strength should be. What should be the strength of the vaccine? Whether it should be 5 microgram or 10 microgram antigen should be there, or 20 microgram. So we have to establish what is the actual right strength to produce the maximum efficacy. So they will give 5 microgram to some out of the 25 people. They will give 5 microgram. 10 microgram they will give to the 5 people, and 20 microgram they will give to the 5 and people. Different strength they will try, and they will see at which strength this particular vaccine is producing the maximum immunogenicity without compromising the efficacy. And in phase 2A, this is a little bigger number, few hundreds they will involved in this trial. And mainly this is expanded safety. We'll get a more expanded safety experience in that. But what we find here is the effectiveness, that is the which dose. So for in the first phase one, we'll identify the which whether, for example, 10 microgram is more effective compared to the 5 and 20. So that 10 microgram will be the dose for conducting the phase 2A. So when we will go for the maximum number of the subjects, that they will identify the exact dose. And also they will may develop the proof of concept. Yes, this vaccine is going to be effective for that based upon the immunogenetic properties. Phase 3 is very important, where thousands of people are involved. It may be at least 25,000 to the maybe 50,000. So it is a huge number of subjects are involved in the phase 3, and it is a multi-geographic areas and heterogeneity is involved. Means trial will be conducted, for example, in India. So we have a different food culture, different genetic properties. For example, the northeast population and Dravidian of your south population and West India Western population, it may be a different. So that's why we will always direct the manufacturer to conduct a trial across India. So we would like to see the safety and same immunogenetic properties across all the populations among the India, and also will different age group starting from 16 years up to the 60 years, different age group population also involved, and different sex also. So male and female also should be the part of the clinical trial in the phase 3. And in the phase 2A, the best schedules also, what should be the vaccine schedule, whether it should be a single dose or multi-dose, that is also they are going to be identified from the phase 2A. And delivery methods, and whether the vaccine is best suitable in the form of oral administration or injection or nasal route. So that route of administration also will be finalized in the phase 2A. More safety data is generated, and also more data on immunogenicity is also developed in the phase 2A. And phase 2B, mainly it is a particular intended population, many few thousands. We will also assess the risk associated with the vaccine, and the proof of concept is also part of this. And phase 3 is very important. These thousands of the people are involved. As I said, it is a multi-geographic area and heterogeneity population. Finally, how we approve the vaccine, this is the most important thing. Uh, Based upon the animal data, phase 1 data, clinical phase 1, phase 2, phase 3 trials, then regulator will review the entire dossier along with the experts, and whether this data generated is able to assure sufficient safety and efficacy of the vaccine. So that will be assessed. If the data is satisfactory, then the regular permission will be granted. However, you may be come across the word called emergency use authorization. So what is the difference between emergency use authorization and the regular marketing authorization is, regular marketing authorization, once the entire data is available and it is satisfactory, then the regular approval is granted. In case of emergency use authorization, still phase 3 trials, means phase 1, 2 must be completed, but still phase 3 trial is going on. For example, phase 3 trial is going on 30,000 people. Out of 30,000, if initially they have completed recruitment of 15,000 people, based upon the 15,000 people data, what is called as a interim data, they will do interim analysis, and they will submit that interim analysis data to the regulators to grant emergency use authorization because of the pandemic situation and because of the emergency situation, and also because of there is no alternative, much treatments are available, whether that particular vaccine can be granted conditional approval as a emergency use. However, the trial will be continued. Out of 30,000, though they must have submitted the data of 15,000, the rest of 15,000, the trial will continue. They won't stop the trial. So as and when they will complete the trial of 30,000, they will come with the full data. So from later on, this emergency authorization may be converted into the regular authorization. For example, if the data, because it is the emergency, to grant emergency authorization also, they have to provide sufficient evidence for that. And whenever we grant the emergency authorization, we'll put lot of conditions based upon that how much data they have generated, and based upon the data only we are able to grant them. But till now we have not yet granted emergency use authorization. In fact, recently we have received 3 applications for emergency use authorization. Out of 3, one company has not turned up for the presentation. 2 companies, they have made a presentation, but we need additional data. What data they have submitted to us was not satisfactory, not a complete data. We asked them to submit additional data for further review of their application. And in this vaccine development, the another you must be come across media about the serious adverse events, and in the news media also you must have seen some, because of this vaccine some problems arise. And as a drug regulator, how we ensure the safety and well-being of the subjects, that means the persons who are involved in the trial. So the clinical trials has to be conducted as per the good clinical practices. We have a well developed guidelines how to conduct a clinical trial, and what are the responsibilities of the each stakeholder involved in that, and what type of facilities the clinical trial center should have, and what guidance documents they should maintain, and how the patient should be protected from any adverse event. So very detailed guidelines have been prescribed by the government of India, that is called the good clinical practices, generally as a GCP guidelines. And these trials are monitored by the regulator. Even the clinical trial site, for example, particular hospital in any particular state, the trial is going on. So the regulator also will keep a watch on the particular trial site, and very important, ethics committee of that particular hospital, they will monitor the clinical trial, because of that protocol. Clinical trial protocol has to be approved by the ethics committee of that hospital also. For example, King George Hospital in Visakhapatnam, if they are doing the clinical trial, and that hospital ethics committee, they have to approve this protocol of the clinical trial, and they will also monitor the clinical. This is their responsibility to monitor for the safety and well-being of the subjects. And it is the responsibility of the sponsor also. The person who is conducting the clinical trial is also responsible to monitor. An investigator, that is generally called as a doctor, who is monitoring the trial, it is his responsibility. And also there should be a data safety monitoring board, DSMB, which is the independent board constituted by the manufacturer, with special experts in that board, and they will also monitor all the uh, adverse events and serious adverse events reported during the clinical trial. So you must have come across the word serious adverse event or serious adverse reaction. So what is serious adverse event? So a serious adverse event means a serious adverse event is any untoward medical occurrence, that any dose that results in a death, or results in inpatient hospitalization, or results in persistent or significant disability or incapacity, or that adverse event lead to congenital anomaly or birth defects. So but we have a very good system. Any serious adverse event reported occurred in the particular person, the doctor, that is investigator, within 24 hours. This is clearly stated in the regulation. Within 24 hours, he should inform to the regulator, he should inform to the sponsor, and within 7 days of that incident, the investigator has to investigate that whether that adverse event is related to the trial or not. That has to be established. In our CDSCO, once if any serious adverse event is reported to us, we have a special expert committee having different experts in that committee. They will review the serious adverse event, and they will analyze whether this particular serious adverse event is related to the vaccine or is not related to the vaccine. If it is related to the vaccine, in general, immediately that sponsor has to hold the trial for time being till it is finally investigated, or if it is not related, that trial will continue. In case that event, the serious adverse event is proven that this is related to the clinical trial, then we have a very good provision under the drugs and cosmetic rules, a provision for compensation. In fact, no country in the world they have such type of provision where it is the responsibility of the regulator to ensure the compensation is paid to the patient or subject participated by the sponsor, by the manufacturer. We have a formula for that, and we have well established mechanism. If something goes wrong with any particular person because of the vaccine, and the compensation will be paid by the sponsor. This is as per the law, it is a mandatory to the sponsor as to pay the compensation. But this is, as I said, these reports are communicated to the DSMB or the drug regulator or subject expert for the causality assessment. And you may be having one doubt how the regulator will, how the experts will assess whether this particular adverse event is affected because of the vaccine or because of any other reason. That means whether it is related to trial or not. If you see the assessing of the relatedness, one is time relationship. That means whether this event is happened after administration of the vaccine, and we have the yes, certain, or a probable, or possible, or unlikely. We have four different parameters that. And if you see the parameters, what we considered, the time relationship. Second is no alternative explanation for that particular event after the investigation. For example, if that particular allergy or something is happened, to produce that allergy, whether that particular protein, whether the biochemical analysis has been done. Okay, if that is proven, they will say if it is yes. And positive de-challenge. That means once, for example, that particular drug during the trial is withdrawn. So after withdrawal also still that event is still continuing, or whether the event is stopped. Say for example, in case of any anti-diabetic clinical, antibiotic drug clinical trial. So anti-diabetic drugs are given every day in the clinical trials. For example, after 10 days, if the event is happened, and even after 10th day, if you stop giving that medicine, even whether still after withdrawal also still whether the symptoms are persisting. And similarly, positive re-challenge means again re-administration. You give a gap of 10 days, after 10 days again you give the drug. When you give again the drug, whether again that particular problem, same problem is reoccurring or not. So based upon these parameters, then they will decide whether it is related to the trial or not. This slide I made just to get some idea about how vaccines are produced. This is about the vaccine manufacturing. Generally, the particular any virus or a protein, what they will select different, for example, if it is a inactivated virus, so the inactivated virus, they will propagate, that means they will multiply in the media, and then that particular virus they will isolate, and that after isolation they will purify that particular antigen or a virus. Then this purified product they will consider as a bulk antigen or a bulk vaccine. So that bulk vaccine they will formulate, then finally they will fill that particular vaccine in the vials. So this is a brief flow diagram about how vaccines are made. So coming to the vaccination, this is just to make you understand if there is no vaccination, what happens. See, for example, here the red color is the person who has, for example, is COVID positive. So if he is a COVID positive, he will spread, he will transmit the virus to different healthy people in the society if there is no So that's why government is so serious about the mass vaccination. So here vaccination not necessary to give only particular category of the people. This vaccine is required for everyone. See, if you give the vaccination, what advantage we'll have? For example, we take one example. If 86% of the coverage, if you give vaccine, after vaccination, after the mass vaccination, so what this red color person still somebody is a positive. That means he has not taken the vaccine, but he is positive. And the gray color person is he's vaccinated, and blue person is not vaccinated. So when the blue person is not vaccinated, this red color, this person, this COVID positive red color, he will transmit the virus to the blue color person who is not vaccinated. So if you see in this how this person is transmitting, but they may not able to further transmit to other because of the surrounding other people are vaccinated. So once if you do the mass vaccination, we can stop that chain. We can block that chain for further any transmission of that virus among the people. If you see how the vaccine efficacy is determined, you must have come across in the newspapers. Some company they will claim my vaccine is 92% efficacy. Somebody says 95%, and somebody claim only 70% of efficacy. So how this efficacy, vaccine efficacy is calculated? Just I try to yeah. I try to make it a little simple. I hope you are able to understand this. So if you see the first, for example, the clinical trial is conducted on thousands of the people. So just I have taken 10 people. So if the trial is conducted on 20 people, for example, 10 is vaccinated. This is the color one, and white one is the unvaccinated. Generally, in the clinical trials are conducted in randomized manner. Means the entire population is divided into two groups. For example, if the trial is 40,000 people, out of 40,000, 20,000 people will get a vaccine and 20,000 people will get a placebo. Placebo means without vaccine. It is just, without the actual drug, rest everything will be there in that product. So that is nothing but as good as like a distilled water. So without any vaccine. So when that is called the randomized trial, the total population divided into the two groups. Similarly, for your easy understanding, 10 people is vaccinated and 10 people not vaccinated. Unvaccinated, this is the called placebo. After vaccination of 10 people, out of 10 people, still two persons, they got COVID positive and symptoms also out of 10. So that's why there is in the one group, there are only out of 10, two people after vaccination, still they got the positive. And unvaccinated, of 10, 9 people got a positive, one person has not got the positive. So the vaccine efficacy is determined out of placebo 10, 9 people got positive. That means 9 minus out of vaccinated, how many people got positive? So out of in the vaccinated group, only two persons, they got the positive, that is COVID positive and also symptoms. So that means the placebo, total positive cases in the placebo minus total positive cases in the vaccinated divided by the total positive cases in the placebo. That means 9 minus 2 by 9 into 100, that will give the vaccine efficacy. So that's why it is not necessary that when you vaccinated, all persons are get protected. Even after vaccination, some people still may get the virus, maybe because of various factors, because of his natural antibody, maybe his body may be not responding much to the vaccine. Antibodies are not produced properly in him after even vaccination. Some people may still get. So that's why vaccine efficacy is depends upon how many people they got positive even after vaccination in the vaccination group, and how many people they got a positive in the placebo. based upon this calculation, they will determine the percentage of the vaccine efficacy. And also you must have seen in the newspaper, some vaccines are the 2 dose. So why it required 2 dose? So, and they say that some vaccine second dose is given after 21 days, or some manufacturers claim after 28 days. So the first dose also will give some antibodies, that is immunoglobulin G, EM, but it may not be sufficient to protect the from the. It may not sufficient to produce proper immunity that is sufficient to protect the body from the virus. So that's why when you give second dose again here, so the second dose will produce the sufficient immunity which is able to protect our body for long time. So this slide talks about various. Please let me know how much time I have, Bharati. Hello.
Yes, sir.
You you can go ahead for another 10 minutes. Doesn't matter even if it spills over by about 15 minutes after 1 o'clock. So maybe another 10 minutes, sir.
Yeah. Okay. So
Will that be
I'll
adequate?
yeah. 10 minutes is fine.
Yeah, please go ahead. Go ahead.
Yeah. Thank you. So this slide talks about what are the various agencies, what are the various experts who are involved in the vaccine approval process. As I said, one is the regulator, that is the Central Drug Standard Control Organization. So what is our main role is at the before development of any vaccine for preclinical, that is for animal testing, we will grant the test license. So without any license, nobody should develop the vaccine. So they have, otherwise we don't know who are doing what and whether it is any that science behind the development is ethical or unethical. That all need to be verified, and also whether that is going to be effect on the environment, effect on the public. So all this will be seen, and they will grant the test license. And CDSU is also responsible for joint inspection along with the state regulators. We will inspect the manufacturing facilities, and we will verify compliance to the regulatory requirements. And CDSU, we also have a subject expert committee that is called SECs. The mandate of the subject expert committee is to review the safety and efficacy data submitted by the applicant. And concerned state licensing authorities, actually, they will grant the test license based upon recommendation by the CDSU, and they are responsible for grant of manufacturing license to produce the vaccine. And the subject expert committees, they evaluate the preclinical, clinical trial protocols and reports with respect to safety, efficacy, and also serious adverse events. And very important thing, before any vaccine is approved or even released into the market, that vaccine will be tested by the government laboratory. So we have a central drug laboratory at Kasoli. So at the time of, even before that vaccine is given to the clinical trial subject, during the clinical trial also, that vaccine, that batch has to be tested by our CRA Kasoli to comply as per the standards. And in the vaccine, another very important feature what we have in India is, even tomorrow, this COVID vaccine is approved for the particular company. When he start manufacturing and he is releasing the batches, before he release the any batch into the market, that each batch has to be tested by our central drug laboratory at Kasoli. So that means batch release is a mandatory in the vaccines, not only COVID vaccine, for all vaccines. But in case of drugs like medicines, the batch testing by government laboratory is not mandatory. And as I said, to enhance, to make it this vaccine is available at the earliest, we had a very good accelerated approval process. And important thing is the accelerated approval process mechanism and expedited review process mechanism. This is included in the regulation itself. This is not just by administrative order, or it is keeping in mind this type of pandemic situations, emergency may arise. The government of India, while making the rules for the clinical trials and new drug approvals, this provision has been incorporated. So the regulator has to follow the accelerated approval process in case of any severity, rarity, or prevalence or availability of lack of alternative treatment, and also in case of any special relevance to the country, any particular disease. So in that case, we had to do accelerated approval process, and also provision for the expeditious review process, and that is based upon the evidence for clinical safety and efficacy have been established, but drug has not completed the all or norms clinical trial phases. In fact, based upon this provision, expedited review process, we are able to give emergency authorization use. Though the normal clinical trial process is not yet completed, but still, based upon urgency, we can give emergency use authorization. This slide talks about the current status of the vaccine in India. So under clinical trial, there are 5 vaccines are under the clinical trials. 4 are indigenous vaccines. 1 is imported vaccine, and 13 vaccines are under the preclinical stage. That is, in the animal study stage. Around 13 different vaccines are that. And just I would like to share you the names of the details of the organizations. The indigenous manufacturers like Serum Institute of India, and their platform is the adenovirus platform. So their phase 2 by 3, that is safety studies they are doing in India. This is Serum Institute is nothing but there is a AstraZeneca Oxford trial. This is developed by the Oxford the technology, and AstraZeneca is supporting there, and they are doing efficacy trial in Europe, Brazil, and other countries. In India, they are doing safety studies. And the second is the Bharat Biotech. It is a wholesale viron inactivated virus. Phase 1 by 2, they have completed that trial, but extended trials are going on. So phase 3 trial, they are enter into the now phase 3. Kedila Healthcare, they are the recombinant DNA, that is mainly a DNA technology. Phase 1 by 2, they are doing. And biological E, this is a recombinant yeast containing RBD antigen. This is the phase 1 by 2 trial is going on that. In case of imported, Dr. Reddy Laboratories are doing the phase 2 by 3 trial. That is the Sputnik Russian vaccine. This is the combined adenovirus vector vaccine. And these are the different vaccines which are the preclinical stage. Serum Institute, other platform. Serum Institute have one platform in the clinical trial, but there's another platform. They are in the preclinical stage. Similarly, Cadila Healthcare, Bharat Biotech, Arvindo, Reliance, Genova, Premas, Cadila Pharma, Panacea, Stelis. So these companies are in the preclinical developmental stage. The government of India is also recently issued a one notification uh, to start manufacturing of commercial manufacturing batches of these vaccines. In fact, as per the existing regulation, the manufacturers can produce commercial batches only after completion of clinical trials. That is what existing law says. But after completion of clinical trial, once if you approve the product, then manufacturer may take long time to produce the commercial batches. Because for the any vaccine, it will take 45 days to 2 months or 3 months to produce a one particular batch based upon that process involved in that. To avoid the delay in supply of the vaccines, Government of India has given a special gazette notification where they have permitted the manufacturers to produce commercial batches during the clinical trial itself. Because of once the clinical trial is completed, the data is satisfactory, permission is granted, then readily that vaccine should be available. But it is a little calculated risk. For example, if the trial is negative result, then whatever quantity they manufactured, it is going to be a waste. But taking a calculated risk and based upon the the importance of this vaccine, we have permitted to produce them commercial batches, but they don't release the batches into the market unless their clinical trial data is seen by the regulator and verified and granted the permission. Then only they can release these manufacturing batches into the market. The major challenges what as a drug regulator we are facing in that is because of these vaccines, I said generally it will take 7 to 8 years to develop, but this vaccine developed in the 7 to 8 months. So we need to really see the follow-up safety studies to evaluate the long-term safety, because of we don't know sometimes the vaccine long-term how, because these are the new platforms, messenger RNA, DNA technology. Is any long-term safety issues, we need to be carefully watch on that. And also duration of immune response. Once a vaccine is given to the particular person, so how many days he is protected? Whether again further dose is required after 6 months or after 1 year, after 2 years, this is also yet to be known. This is another great challenge. And also the complete measures of efficacy, because of the data what at present reviewed is a interim data. So the once the complete data will come, the actual efficacy, and after that we also need to see the effectiveness of the vaccine. So the difference between efficacy of the vaccine and effectiveness of vaccine is efficacy is seen during the clinical trials. Effectiveness is seen after approval of vaccine when it is used in the mass population, in a huge number of people, how the vaccine really working in the real world scenario. Another very important challenge is transmission of virus from vaccinated people. So even after vaccination, if somebody will get this vaccine contaminated, affected, a virus is affected with that vaccinated person, he may not able to have any symptoms. But whether he will transmit that virus to any other people, so that is another big challenge. Also need to be further confirmed. And most of the clinical trials we are doing an adaptive design, that is parallelly different stages of the trial is going on. With that also is great challenge. Another great challenge is availability of container closure syringes. So to administer this vaccine, we need syringes. So regularly we have syringe manufacturers in India. Their manufacturing, their capacities are limited to whatever other injections we are using at present in India. So for example, tomorrow in the first phase, if the government is decided to give 30 crore population in India to give the vaccine, we need 60 crore syringes, because of each person require two syringes. It is a two-dose vaccine. So manufacturing 60 crore syringes in a period of next, this should be the additional capacity. The existing capacity they may be doing routinely for their other routine regular use. So we need to have a 60 crore syringes, and then later on again for if you want to give it to the more number of people, we need a more. Similarly, container closures, the vaccine is filled in a vials. So we need to have so many vials, so many rubber closer for that. So these are all are the additional requirements. So in fact, that's why Government of India is closely collaborating with the stakeholders to see that all ancillary products, ancillary items also simultaneously available whenever this vaccine is going to be launched in India. And also there is a lead time for packaging cold chain vehicles because of this vaccine like minus 70 degrees centigrade. How we can transport this? That means we need that cold chain vehicles which can able to transfer a vaccine at minus 70 degrees centigrade. And supply chain is going to be a big challenge to everybody to make available that safe vaccine at all places. So in my conclusion, this is really a challenging time for the regulators. One side that we had to ensure the safety efficacy. Other side, we have to make this vaccine available at the earliest, and it should be accessible, and it should be affordable to all the needy people. And also making this available, accessible of this vaccine is one of the major responsibility. And also the production capacities. Fortunately, we have maximum production capacity in India. And the new technologies, these, and we should be very, very cautious of the long-term safety issues also about this. And we will always has to take a decision based upon the benefit risk assessment. As I said, no drug or no vaccine is 100% safe or 100% efficacious. So as a regulator, we have to balance both the benefit and risk. And another great challenge post-licensure monitoring. Once the vaccination is given to the mass population, then monitoring of any events, say related or non-related to the vaccine, to be properly monitored. And that's why if you see the both the government, central government and state governments are closely monitoring of the production of this vaccine and also the supply chain and also training. I think Government of India has already issued the guidelines on the vaccine distribution and the guidelines on various activities relating to the vaccine distribution. So thank you very much for your kind attention. I'm sorry, I think I took some 10-15 minutes additional time. So over to you, Bharati.
Yes, sir. Chakrapani, sir.
Uh, Thank you, Mr. Ishwar Reddy Garu, for a very lucid, very exhaustive, a very objective, and a very uh, giving a lot of hope to people of this country insofar as the regulatory process is concerned. I'm really very happy we did not know that such a detailed process is in place, and I think it gives a lot of assurance to all the informed and uninformed sections of this society. And I'm very happy that this program is being attended by about 1,000 participants in the Cisco WebEx and also another nearly 200 in the YouTube. I think it has received a lot of attention from different parts of the country, and people from uh, various corners of the country, including Mizoram, etc., are able to hear you and understand the processes relating to vaccination. I have one or two points. I'm sorry we do not have much time for discussion because the next presentation is also there. One point is, what about the clinical trials relating to other systems of medicine, like Ayurveda, Siddha, etc.? Have you received any requests? That's one. The second thing is, how soon do you think this processes would be, the vaccination would start? Do you think it will be possible in the next 1 or 2 months or maybe longer? The last point I would like to, I'm very happy that you have spoken of the collaboration between the Drug Control Authority and the APHRDA. I'm sure the APHRDA management would be more than happy to collaborate with a very respectable and a scientific organization like the Drug Control Organization, so that the dissemination of information can take place. So over to you, Mr. Reddy.
Thank you, Chakrapani sir. I think the first question about the other systems of medicine under the Drugs and Cosmetic Act. This act recognizes the all systems, the allopathy, Ayurveda, Siddha, Unani, homeopathy, all have been recognized. And this is the same act. Drugs and Cosmetic Act is the remain same. Under the same act, we are regulating all systems. But for allopathy, we have a very detailed regulations for conduct of clinical trials. But unfortunately, for Ayurvedic drugs, there is no specially defined clinical trial regulations. The reason is these Ayurvedic drugs, this all whether it's herbal or other related, they claim these are the established molecules, established product. Say, for example, if somebody wants to use tulasi or any turmeric or other things, so they say that they have the standard book of reference where that particular product has been already identified for the particular indication. Coming to the vaccines, I think there is no till now nobody has come forward for the Ayurvedic vaccine or homeopathic vaccine, but I don't think so. They can able to come with that vaccine because of vaccine means it has to be a purified compound. The moment it is a highly purified isolated product, then it comes under the default by definition of allopathic drug. It has to be in injectable form. So there are no at present any proposal for the Ayurvedic or homeopathic vaccine. Only allopathic vaccine trials are going on. Your second question: when will expect this vaccine will be approved for emergency use in India? So as I said already, we have received three applications. One is the Pfizer application for emergency use, but this company, they did a clinical trial outside India. They have not done clinical trial in Indian population. So this is the one. This is the one of the great challenge for us, approving the any vaccine without conducting the clinical trial in India. However, our regulations permits approve such approvals even without conducting the clinical trials in India. Once the product has been approved by any other international well-established regulatory authorities, provided if it is for the any national emergency or pandemic situation. Two Indian companies also made application. One is the Serum Institute, another is the Bharat Biotech. As I said already, we have reviewed their application and we asked for some additional data. So we are waiting, waiting. This company should submit this additional data. So as soon as they will submit this additional data, so immediately we will review on accelerated approval process. And once they submit the data, if the data is found satisfactory, within 2-3 days after the submission and the data is satisfactory, we will grant the permission. So the third point with relating to the collaboration, I'm very happy to happy to see at the time of your introduction about your organization. I think you are doing excellent job, and I think whenever I'll be in the Guntur and that side, I hope it is near to Guntur. So
Yes, sir.
I will. Okay. So we will physically verify your facilities also, and we will see that at least the South Indian regulators, among all the South regulators, we can have some training programs at your institute initially.
They have two regional centers also, Mr. Vishnu Reddy. One is at Kalahasti, Chittoor district. The second is at Visakhapatnam with well-equipped facilities. So you may kindly keep that in mind. Thank you.
Sure.
So Chakrapani sir, only the founder director of general of this institute, sir. So
Okay.
definitely we will take this idea forward. We will inform the same to DG sir. And thank you so much, sir, for your wonderful presentation and offer collaboration effort with the HRD. And now the second presentation is on vaccine experiences of JSS in clinical trials by Dr. Juni Sebastian Ma. Dr. Juni Sebastian ma'am is a faculty at the Department of Pharmacy Practice, JSS College of Pharmacy, JSS Academy of Higher Education and Research, Mysore. She has completed her undergraduation, post-graduation and Doctor of Philosophy from JSS College of Pharmacy, Mysore. Her PhD research was in vaccine safety. She is currently involved in training PharmD and postgraduate clinical pharmacy students and PhD students while providing patient care services at JSS Hospital. As a pediatric pharmacist, she works in collaboration with the Department of Pediatrics and coordinating vaccine safety studies at JSS Hospital and is a part of multi-country collaborative vaccine safety studies of World Health Organization. Juni also works as a clinical trial coordinator for medicine and vaccine trials. She attended an advanced vaccinology course at International Vaccine Institute, Seoul, Korea in the year 2014 with the fellowship. She received travel grants and scholarship to attend international conferences. The area of vaccinology and pharmacoepidemiology in Singapore, China, and Japan. She has 40 publications in peer-reviewed journals and made more than 20 research presentations. Madam, it's my pleasure to invite you to this session, and now I request you to kindly take the session.
Thank you, ma'am, for a wonderful introduction. I hope everyone can hear me and see my slides.
Yes.
Okay, thank you, sir. And I also was not knowing much about this the organization and came to know about it. Okay, anyway, I'm very thankful for the organization to give me an opportunity where personalities like Dr. Ishwar Reddy sir is giving a talk. So I will, in the next 30-40 minutes, I will be just discussing on how exactly we conduct vaccine clinical trials, or what is the experiences of JSS Hospital in conducting the vaccine clinical trials. So we conduct both vaccine as well as drug clinical trials. Even nutritional supplements clinical trials also will be going on in the hospital. So the presentation outline is like this. So I will be giving a brief introduction about the JSS Hospital and JSS Academy of Higher Education and Research, and the strength of JSS in conducting clinical trials, and what kind of infrastructural and training modifications we have made in the hospital to accommodate the vaccine clinical trials. And I'll tell you briefly about the experiences of conducting vaccine trials and what are the challenges we have faced in pertaining to clinical trials during this pandemic. So this is how I will be taking over my presentation. So this is the picture of JSS Hospital. JSS Hospital is a 1,800 bed hospital which is in Mysore, and this is a teaching hospital, and it is attached to JSS Academy of Higher Education and Research. And JSS Academy of Higher Education and Research has various colleges and various programs offered by them. We have medical college, pharmacy colleges in Mysore and Ooty. We have dental colleges, and we have various faculty of life sciences courses and health system management courses, and all the health related courses we are offering. And this hospital is in the Mysore city. And this is 1,800 bed, as I already discussed. And the hospital is having 37 multi-speciality units, and the patient turnover is too high in this hospital. So this hospital is NABH accredited. And in coming clinical trials, especially when we are talking about the clinical trials happening in JSS, we have a CDSA CCRE. CDS is a Clinical Development Service Agency sponsored Clinical Trial Research Excellent Unit. CDS CCRE, we generally call it. This is a DBT, Government of India actually recognized JSS as a Center of Excellence in clinical trials in the year 2015. So from then, the particular CCRE came in operations in 2016 and managing the clinical trial. Even before this particular unit is identified in JSS University or identified as university trials. After the introduction of the CDSS CCRE, it became more systematic, and many more trials came in place after this. So this CDSS CCRE has different objectives. So they have mainly two objectives, and they are coordinating. They are the coordinating center for conducting high quality and ethical clinical research as per the good clinical practice guidelines. Then they conduct GCB, good clinical practice, and other clinical trial associated training for the study team. So whoever is there in the hospital are a part of the clinical study. The clinicians and hospital staff, the CDSS CCRE will be giving training to equip them for conducting good quality clinical research. So the CCRE generally give different services to the sponsors or the different clinical trial organizations. So they will identify suitable, we have a very good health team of healthcare professionals in the hospital. They will identify the suitable principal investigator for the clinical study. So the principal investigator, Sir Ishwar Reddy sir has explained very well who is a principal investigator and all. So principal investigator is a doctor who is taking care of a clinical trial in a particular hospital, in a study site. So from our side, if any company wants to identify or wants to conduct some clinical trials in our hospital, the CCRE will identify the suitable principal investigator for that particular clinical trial. So you cannot have any person as a principal investigator. So the principal investigator need to have a good experience in conducting clinical trial, should have good training in conducting clinical trial, especially on good clinical practice, and should have proper education. So so who is a suitable PI for a particular clinical study will be identified by the CCRE division. Then there is sponsor and hospital, like principal investigator. They will act as a liaison between the sponsor and the principal investigator. And before initiating any clinical trial, the sponsor or the clinical research organization visit the study site to understand what are the different infrastructure facilities what we have to conduct the clinical study. So those kind of visits are called as pre-study site visit. So those kind of study site visit, and the initial workup will be done by the CCRE. Then they will identify whether the hospital can be eligible for conducting clinical study. So these are some of the free services offered by CCRE to any sponsor or CROs. And they also support in ethical committee submissions, like if the company is facing some difficulty to submit some documents to ethical committee, then the ethical committee, they will support them. Then for DCGI approval, so how exactly the documents to be submitted for DCG approval, that they will support. Then for a clinical trial registry of India registration, then preparation of consent document. So the ethical committee, the consent document, when we are conducting a clinical study in a particular state, we need to have a consent in the local language, because we will be recruiting the people from the locality. So we need to give the informed consent document in the language of their preference. Suppose in Mysore, when we are conducting clinical trials, most of the patients, they prefer having a informed consent in Kannada language for better understanding of the risk and benefit of the clinical study. So generally, the informed consent form will have the risk and benefit of the clinical study, whom to be contacted for when there is a related injury, whom to be contacted, what is the process of clinical trial, what is the total number of patients recruited for the clinical study. All those details will be present in the informed consent document. So when the document need to be in the local language. So the CCRE will generally help them to convert so when the sponsor is preparing the document, it will generally be in English language. So to conversion of that into the local language, the CCRE generally helps. Then they prepare the standard operating procedure for various clinical trial related activities. And they make sure that we have each and every clinical trial is done in compliance with the sponsor regulations and institutional review board guidelines. And they also help the study team for sample collections, specimen collection, and for the investigational product coordination, like where to store, how to keep it, and what are the storage area required for keeping the investigational product. All that they support. Then they will be supporting the sponsor for interim data management for the submission to DSMB and all. And they generally undertake audits and monitoring. So these are the different CCRE services which is offered at JSS Hospital. And as we know, or Ishwar Reddy sir has clearly described what are the regulatory requirements for giving approval for a clinical trial. Like before conducting the clinical trial, they need to submit all these documents to DCGI and they will give an approval for conducting clinical trial here. So after getting the approval from the regulatory agency, that is CDSCO in India, so suppose if the study is happened in multiple sites, maybe if the clinical trial is happening in 10 different hospitals in India, the documents which is approved by the DCGI need to be submitted to various ethical committees. Okay, so each and every ethical committee will have a specific standard operating procedure for submitting the documents to the ethical committee. And these ethical committee will be looking into the local, like in a local person's perspective, whether or the ethical committee will make sure that the rights, safety, and well-being of the trial subjects are protected during the conduct of clinical trial. So that is a major role of institutional ethical committee, so that they will think in the localized in that patient population. They will check whether each and every institutional ethical committee will be specific for one hospital. So they will look in how exactly the clinical trial is conducted at the particular hospital. So when though you are getting a CDSCO approval, the company or the hospital need to submit this document to their respective ethical committee. And once the ethical committee is approved, only then you can start the clinical trials. So, and this ethical committee need to be registered in the CTRI. Like you need to submit the ethical committee standard operating procedure, the composition, everything to CDSCO, and you need to register that. So once you have registered the ethical committee, the registration generally, the time period or the expiry for the registration is 3 years. So once every 3 years, you need to submit the documents and there should be a re-registration has to happen for the ethical committee. So only the registered ethical committee can give the approval for conducting clinical trial at the site. So generally the sponsor will look in while identifying a trial site for conducting the clinical study, they will check whether the particular study site is attached to an institutional ethical committee which is registered under CDSCO. So this the ethical committee registration regulation came in 2013. So initially our JSS Medical College has an institutional ethical committee. So this ethical committee was registered initially in 2013. Then we got a registration in 2016 and currently we are re-registered in 2019. So we have a registered ethical committee for giving approval for conducting clinical study here. Then our ethical committee, the institutional ethical committee is NABH accredited. So in the year 2018, we were first accredited by NABH. And the ethical committee is very functional and has a very elaborate standard operating procedure for each and every activities which is conducted by the ethical committee. So for the submission, for the review process, for the interim analysis, all that we have a standard operating procedure. Then coming to the vaccine clinical trials, that institutional ethical committee is same for all the vaccines and drug trials. It is for the drug trials or any kind of academic project, we need to get the ethical committee approval. So coming to the immunization center at JSS Hospital, which takes care of all these vaccine trials. So this is the immunization center at the hospital. So we have very well-trained staff nurses who give the vaccinations. So it is the only trained staff nurse will be giving the immunization at the immunization center of JSS hospital. So we have, and like in the JSS hospital is a private hospital, but JSS hospital is also identified as a center for giving the vaccines through the EPI program. So we also receive vaccine supply from the government, and we will be storing in the immunization center and will be giving to the population. So like any other primary health center, we will be giving vaccinations to all the populations in and around Mysore. And our immunization days are on Mondays and Thursdays. But all other days we do vaccinate, but not by the vaccines which is coming through EPI program. In our pharmacy, we have all the, like in the EPA program, we have only the mandatory vaccines, but optional vaccines are present in the pharmacy. So if any patient wants to receive the vaccine, they can buy from the pharmacy and can bring to the immunization center, and staff nurse will administer with the doctor's prescription. So likewise, we are giving both mandatory as well as optional vaccines in our center. So as a part of that, we have an active vaccine safety surveillance program in place in the immunization center, which is managed by Department of Pediatrics and Department of Clinical Pharmacy. And what we generally do is active vaccine safety surveillance is a kind of post-marketing surveillance. So generally we know when you are, generally we hear the vaccine is given, then there was a problem happened, and all that thing generally happens. So once the vaccine is given at our immunization center, what we do, we will follow them. We will collect the mobile numbers of all the population who is getting vaccinated here, and we will make a phone call to them after 8 days. So every patient will receive a phone call after 8 days, and we will inquire them what kind of safety problems they develop. It can even be a mild reactions like fever, all that. So we have the active vaccine safety surveillance there. And as far as, and all the, whenever, if there is a serious adverse event occurred, or there is an anaphylaxis or something happens there, what we do, we will be reporting to the district immunization office, and thereby from there it will be going to the state and central government. And all other programs, all the minor AFI or fever or that kind of adverse events will be reported to the Pharmacovigilance Program of India. So Pharmacovigilance Program of India, like the JSS hospital is identified as an ADR monitoring center. So through that program, we will be reporting to even to the PVPI program. So this active vaccine safety surveillance is existing in JSS hospital from the year 2013. So there are two parts: initial monitoring. So every child after vaccination, we will ask them to wait in the waiting area for minimum 30 minutes. Only then they can go home. And following to that, we will call them after 8 days to identify any kind of safety concerns. And because we have all these programs in place, World Health Organization has identified our hospital as a sentinel site for conducting global vaccine safety multi-country collaborative vaccine studies. So we were a part of WHO from the year 2015, and we conducted one study initially. At that particular time, we were only one site in India. We were providing data for WHO. Currently, we had another study which was identifying the adverse birth outcome following vaccination when the mother has received the vaccine. So that was a pregnancy-related study, and that was just going on. It just got over last month, and that was the WHO multi-country collaborative studies. Then we have a good infrastructure in the immunization center. We have a waiting area, and you can see there is a area here inside the immunization center to treat the patient when there is an anaphylaxis or any kind of serious events which happen within 30 minutes of vaccination. So this is, I just wanted to show some of the publications we made from the active vaccine safety surveillance. So this paper published in the journal Therapeutic Advances in Vaccines and Immunotherapy. And this was 3-year active vaccine safety data we have actually published. It was one of the well-cited paper which is published last year, 2019. And this is the publication which we made as a part of, like when we were a part of the WHO Global Vaccine Safety Multi-Country Collaborative Study. So this is what was the publication came out of that. And the government has an AFI surveillance system for all type of vaccinations. So we said we are having an active vaccine safety surveillance. So similar way, the government has an active vaccine safety surveillance. So we can see here the total population, like the green color the emojis are the vaccinated population and some are not vaccinated. And out of that, few may develop the safety problems. It may be a seizure following a DTP vaccine or a rashes following measles vaccination, something like that, some problem they are developing. So suppose if there is a serious adverse event. So Ishwar Reddy sir has already given us the criteria for a serious adverse event. If the event leads to death, or if it is leading to a hospitalization, or there is a congenital anomaly or a permanent disability or a life-threatening event, we classify it as a serious adverse event. If the population is developing a serious adverse event, or they are developing a cluster of event, or a parental concern, there are some criteria for reporting. So if they are developing the adverse events, so they will be, it is not necessary that they will be coming back to the primary health center. They may go to any hospital or a clinic or a community, wherever it is. And when they are going, we have the surveillance system. The government has a surveillance system to collect all these cases. So all these cases will be collected and they will be reported, and there will be further investigation. So once we report the case report form, the district immunization office have a field worker and they will do the further investigation. And the final report will go to the central unit, where the risk causality assessment will be performed. And after the causality assessment, they will classify the adverse events into consistent causal association to immunization. That means the vaccine, the adverse event is occurred due to this particular vaccination. Or it is indeterminate causal association. That means it may or may not be. We are not sure whether it is because of vaccine, and we are not sure whether it is not because of vaccine. So it will be acted as a signal, or we need a further investigation to understand these kind of events. And we will be again classifying one more classification, that is inconsistent causal association. That means it is not because of the vaccination. It was a coincidental event, which may be like following vaccination, the child has developed a fever and got hospitalized, and it became a serious adverse event. But after 1 or 2 days, we understood that the patient is presented with a dengue or malaria, something like that. So initially we might be feeling it is because of vaccination, but it may be something different than that, because during the vaccination time, the virus might be in the incubation period and has developed this. So this is the government system for doing this. So JSS is also a part of the thing, because in what we have seen in our hospitals, many a time the people will be receiving vaccination from a primary health center or Anganwadi or wherever, and they develop some kind of adverse event, and at that particular time there won't be anybody to reach in the Anganwadi or somewhere. So they will be going to some of the nearby hospital. Likewise, we get some of the cases of adverse event. But though we are not a part of government program, we will definitely reporting to the district immunization office. So this also will be done as a part of the active vaccine safety surveillance, which we are having in our hospital. So other than these strong programs or strong support to the government, we have a very well educated, trained and experienced healthcare professional. We have a very good number of doctors, nurses, pharmacists, very well educated and well trained, and we have a very good student community. They are our strength. And we have, when it comes down to the vaccine trials, we have a dedicated clinical research coordinators who is very well trained to manage the vaccine clinical trials. And we have an in-house archival facility in the hospital for storing all the different study-related documents. So this is the immunization center in our hospital. So we can see there is a waiting area, and you can see some of the chairs over here as well. So after the vaccination, we will ask them to wait in this waiting area for minimum 30 minutes to understand any kind of immediate adverse events. And when it comes to the clinical trials, we have a very good facility for the AV consenting. So AV consenting is when we are conducting the clinical trial. I told you that there is about the informed consent document, but the informed consent process I am talking about here. So when you are having a vaccine clinical trial, generally we recruit the vulnerable population. So when we are having a vulnerable population, or we are conducting the clinical trial for a new indication, then we need to have the consenting process need to be audio video recorded. So generally, the investigator has to give all the information about the clinical trial to the patient, to the study population. May not be the patient, it may be the vaccinee or the volunteer. And he has to give all the information. And we should, if the person is voluntarily willing, only then we can enroll them into the clinical study. So generally, the vaccine trials are conducted in a vulnerable population. It is mandatory that we need to have an AV consenting for the clinical trial. So in our hospital, we have a specialized room for AV consenting. And we have the specialized room, the requirements like audio, video, all that kind of facilities we have for consenting. Then initially we did not have that. This audio video consenting concept came in place in 2013. So before that we never had this kind of facility. So we have created a facility for this AV consenting. And nowadays, most of the clinical trial, we are not going with a paper CRF. Like the data collection form may not be in a paper. Instead, it will be there in the electronic, it may be a software-based document. So there is an electronic data capture. So we have the facility for electronic data capture. We have a strong internet connectivity and all that. And we created, so initially after the AV consenting introduced and all, we had some kind of hesitancy in for the population to come into the clinical trials, all that. So we have created some patient charts like this. So which has said, this was actually issued by the Institutional Ethical Committee. So they have given what are the rights of the subject who are enrolled for a clinical study, or what are the responsibilities of subject in enrolling the clinical study. So these kind of boards we have placed in the AV consenting rooms so that they can understand what are their responsibilities and what are their rights while doing the clinical trial. So these kind of posters we have made in English as well as in local languages, and we have made placed in the clinical trial area so that they can understand how exactly they have to go ahead when they are enrolled for a clinical study. Then we have adequate number of cold storages. When it comes down to the vaccines, we know it has to be stored properly, and we need to have proper refrigerators. We need to have a proper ice-lined refrigerators. We need deep freezers, all that. So we have adequate number. So every trial needs a separate facility. You cannot have one particular facility for keeping more than one trials. So generally, we know in our primary health centers or in our hospital, we will keep all vaccines in one storage, maybe in a different compartment, we will be storing it. But that doesn't go well with the vaccine trials. But every vaccine trial need to have a separate storage area, maybe a refrigerator, if it is a deep freezer or whatever they need. And again, we need to have a similar facility, one more for the backup. If there is any kind of temperature fluctuations or something, we need to use the other vaccine. Like without any interruption, we need to do the clinical trial. So we need to have a backup. So we have adequate number of cold storages in the hospital for any number of clinical trials. Then we have the facility for managing emergencies of such as anaphylaxis and all within the immunization center itself. So this is an outpatient department. The immunization center is situated in the outpatient department, and just above the next floor of that is the inpatient ward. So we do not want even to take the patient to the ward or inpatient area without taking there. Like in the immunization center itself, we have the facility to manage the immediate adverse events. Then there is a specific area allotted. So you can see here there are some more. So the picture is not fully taken. So this area is specified for monitoring of adverse events. So this is the population will be waiting for the vaccination or for the OPD. But this area is specified for the 30 minutes monitoring. And we have immunization center staff well trained to monitor what are the immediate side effects. So the nursing staff will be always available here, and they will be observing the population once they have vaccinated and will understand what kind of adverse event, or they are well trained for doing that. And our immunization center is was inspected by CDSCO and NABH and even the WHO team, and they well appreciated the immunization center. So coming to our experiences, I was initially thinking I need to explain what are the different phases of clinical trial or what is the importance of doing the clinical trial, all that. But sir has given a very detailed description on what happens in phase 1, phase 2, phase 3 and phase 4 clinical study. So very briefly, I will also tell there generally a preclinical development generally happens. So after the preclinical development, the companies will approach the regulatory agency for getting an approval to use the product in human beings. So then it enters the phase 1 clinical trial. In phase 1 clinical trial, generally when you look in, very small number of population will be taken, and they are looking for the primary aim of conducting phase 1 clinical studies to identification of safety. So very small number of participants, generally very healthy population will be taken, and generally less than 100 population will be taken for phase 1 clinical study. Then after the phase 1, it enters the phase 2 clinical study. So we will recruit a little larger population, maybe of same age group in case of vaccine trials, like which is meant for which age group. To that age group we will be looking in. or if it is a drug trial, we will go with the specific diseases. So the main aim of phase 2 study, is the efficacy, safety and efficacy. When it comes to phase 2, it is safety and efficacy. So the phase 2 is actually called as therapeutic exploratory phase. So we can understand we are exploring the therapeutic efficacy of the drug or vaccine in phase 2 study. So we will recruit hundreds of population for clinical study in phase 2. Then the study will enter into phase 3 clinical trial, where we will enter thousands of population. And here this phase is called as therapeutic confirmatory study. The efficacy and the safety we are confirming in phase 3 clinical study. Okay. Then after the phase 3, now sir said that there are 3 companies have approached for marketing approval. So that means they have cleared the phase 3 and they are entered into the marketing approval. So after phase 3, there will be a DCGI review happens, and they will confirm the safety and effectiveness. And initially, if they are, sometimes they will, like he said, no, the data was not sufficient, and they have they asked for some more data, and the company will take some time. So in between, they will give some permission for manufacturing for the marketing. Like though they did not give approval, they will ask them to manufacture for the marketing. Then once the DCGI review is completed, we will get a drug approval for clinical study. Then the trial, or then the vaccine or the drug or whatever, it enters into the phase 4 clinical study, where like what is the importance of phase 4 studies? In phase 1, phase 2 and 3, you can see what is the total number of population enrolled. If you are enrolling 100 population in phase 1, maybe 1,000 in phase 2 and 10,000 in phase 3. So altogether, maybe 1,400 or 1,300 population will be enrolled during a clinical trial. But when it comes to the market, and there is a strict inclusion-exclusion criteria we follow for enrolling volunteers into phase 1, 2 and 3. But then what actually happens when they enter into the phase 4 clinical trial, there is no inclusion-exclusion criteria. It is in the community, and everybody are taking the vaccine. Everybody are taking the vaccine or drugs. So then generally what happens, these trials are happened only for fewer short period of time. Maybe for generally vaccine trials, you give one vaccine, follow them for 28 days, trial is over. Or after 28th day, you will collect the blood sample and you will be testing that for the immunogenicity, and what happens during 28 days, we will observe. But there are some instances where the population develops adverse events after 28 days. So the long-term safety and the effectiveness, all that cannot be actually fully established during the clinical trial. To understand the long-term safety and the rare adverse events, all that we generally understand from the phase 4 clinical study. So there, the government comes with an active vaccine safety surveillance, all that to understand or to make sure that it is safe. So when it comes to JSS, we are taking care, we are conducting clinical trial for phase 2 and 3, not phase 1. So we have experience in conducting phase 2 and 3. So I'll just give you quickly, I'll tell you what are the difference between drugs and vaccines, or why we are giving we are taking care more the vaccines than drugs, or we are discussing more about vaccine surveillance than the drug surveillance. Vaccines are generally, we know it is given in a healthy individual for a larger population. You can just imagine if you are going to give the vaccine for currently, how many population will be receiving in short period of time. But drugs are not like that. We will generally give to a ill patient and for a smaller population. Like if anybody develops a disease, we will give. It is not that entire population or entire healthcare professionals are going to receive the drugs. So it is different. And we have a very limited number of product. Sir said we have some 45 or 47 number of vaccines we are manufacturing. Actually, we have the vaccines available to protect or prevent for 27 vaccine preventable diseases. But we have so many different drugs in market, and there are so many drugs available. Like as a generic product or as a fixed drug combination, we have too many different classes of drugs. Then with a single dose, there is no potential for a coincidence in case of drugs, but there is with one dose, maybe many a time we have only one dose given, and there is a greater chance for coincidental events. And there is a possibility of program errors. So like some kind of errors can happen with vaccines, but that is not with the drugs, because the vaccines generally be administered by many people, like healthcare professionals, and in different settings, like in the primary health center, then secondary care health center, tertiary care center. So in different settings we give, And there is a possibility of and without like in Anganwadis or wherever we give, so there is a possibility of having some kind of errors in when you are giving a vaccine. But that is not the case with drugs, and vaccines are biological product. We need to maintain the temperature, all that. Then generally the vaccines are given in mass immunization campaign. That is not the case with drugs. So vaccines are very special. We need to have an extra care while giving the vaccination to the public health program. So then coming to the audio video consenting, what we were discussing. So I told you already the audio video consenting initially came in 2013, and which mandated the audio video recording of informed consent process. The informed consent process was existing much before, like from the time we have the clinical trial, as per the regulation, we have to have the informed consent before enrolling anybody into the clinical study. But this audio video recording for having the informed consent was not existing before, and it was came in 2013. And in 2015 July, there was a modification came in, and they said if the trial is happening for a new chemical entity or for a new molecule, or if the trial is enrolling vulnerable subject, then you have to have the AV consenting. If you are not enrolling a vulnerable population, or the trial is not for a new chemical entity, there is no need of audio video consenting. Okay. So initially, we also did not have any facility in the hospital for audio video consenting. Later, we also incorporated. But this is a study which is conducted in India after the 2013 regulation. So this is has conducted in South India actually, and they found that more than 1/3, that is 34% of the population refused to give consent. They wanted to be a part of the clinical trial, but they refused to sit in front of the camera and undergoing the audio video consenting. And many of them were not interested in recording and don't like to be recorded. So many a time, when it comes to the pediatric population, the child will be brought to the hospital with the mother and grandmother. So many a time what happens, and they do not want to sit in front of the audio video. When you say there is it will be audio video recorded, they need a permission from the other member of the family. Likewise, we had some facility. So the initially when the AV consenting process came, the people were hesitant. They were very scared of what we will do with this video, or they need an extra permission from the other members of the family. And when they call them, they will deny. So likewise, we also had. So the study had shown 34% of refusal, but we did not have so many. But obviously, there was a delay in recruitment process even in our setup. What we have given, we have reassured. I have already shown you some charters, which is given by the ethical committee. We placed the posters over there. We spoke to the patient, and if the study is having a lady investigator, for ladies, the person has taken the informed consent. Likewise, we have given more and more, or we have faced the challenge by giving those kind of facilities in our hospital. And again, another challenge while conducting the trial for children, vaccine trials generally. So we need something called as an assent. So all these days we were discussing about a consent where any study volunteer has to give a written agreement that they are ready to be a part of the clinical trial. But when it comes to a population who is aged less than 18 years, we need an LAR, legally acceptable representative signature for enrolling into the clinical study. So generally, if the child is less than 7 years, less than 7-year-old, then only the consent from the parent or legally acceptable representative is enough to take part in the clinical study. But if the population is between 7 to 12 years, or less than 12 years and more than 7 years, we need to get a verbal assent from the child. Okay, the child also should agree or verbally agree that he is ready to take part in the clinical study. Plus, along with that, the consent need to be there from the parent or LAR. So without the consent or without verbal assent, it doesn't exist. Both has to be there for recruiting the people into the clinical study. And if our study population is aged more than 18 years, more than 12 years and less than 18 years or minor, then if it is more than 12, it is verbal assent is not enough. They need to have a written assent and a consent from the LAR. So that was also one of the challenge when the child need an agreement, how much the child will understand. So we need to be inform them very well, and we need to. So these kind of problems we had, and we were very well. The investigators are very well trained, and like if they need English, so the people versed in English will be engaging them. Or if they need a local language, and the population who knows the local language will involved in taking the informed consent. Likewise, we have faced this challenge. Then another challenge is a placebo-controlled trial. And Ishwar Reddy sir has clearly explained what is a placebo-controlled trial. So generally, when 100 population is enrolled for a clinical study, we will randomize them into test group and control group. Test group will receive the investigational product, and control group receive the placebo. Placebo is nothing but the product which exactly looks similar to the investigational product, but doesn't have an active ingredient. It may be a water for injection or something in case of vaccines. So there are 4 situations where you can use this placebo, where when you are developing a locally affordable vaccine, or when we are evaluating a local safety and efficacy for an already existing vaccine, or testing a new vaccine when an existing vaccine is considerable inappropriate, or like a situation like as a COVID vaccine. So when they conduct the clinical study, there is an approval for having the placebo group. Otherwise, if these criteria are not fulfilled, generally they do not get permission to conduct a placebo-controlled clinical study. So instead of placebo, they have to, suppose if they are coming with a vaccine, a new vaccine, where already another vaccine is existing, or there is a standard of care is already available. In that case, they cannot go with a placebo group. They will have 2 groups definitely. One group will receive the investigational product, and another group will receive the product which was already available in the market. And it will be a standard drug will be given in another group, and the data will be compiled. The data what we generated from the investigational product will be compiled with the already existing drug for the evaluation. So a situation like pandemic or something, in that time they will get a placebo-controlled clinical study. And generally, when we have a placebo-controlled clinical trial, it is very difficult for us to convince our patient population, because we have to compulsorily tell them that there is a possibility that they may receive one placebo. So that means they are receiving an injection without having an active ingredient. So that was also one of the problems. So we have to explain them how the trial or how the study is going to benefit the community. So for the benefit of the community, they can be a part of the clinical study. So that kind of counseling or making them understand was also another challenge what we faced during a clinical study. Then again, cold chain maintenance. So we need to maintain the temperature from the time during all the different phases of a vaccine development, from the time it is in the preclinical study, during the manufacture, and while transporting. Now, you know, it might be manufactured in some North Indian region or somewhere, and it has to be given to all the different hospitals, primary health centers everywhere, and it has to be transported using different routes. It may be air, rail, road, then okay, and all these places we need to maintain the particular temperature. If it is 2 to 8 degrees centigrade, or if it is minus 20 degrees, it is very difficult for us to maintain the cold chain. So even we faced some kind of problems in maintaining the cold chain during the clinical study, because always we need to monitor the temperature, and we need to have an alarm in the cold storages to identify there is a temperature fluctuations, all that. Then temperature monitoring during off hours or holidays was also a problem. Then we made a standard operating procedure for checking the cold chain maintenance, and we made that as a part of the process itself to take care of the vaccines. Then what kind of procedures needs to be followed during fluctuation when there is a fluctuation alarm. So this was the procedure, how to attend to a fluctuation, like when there is a temperature fluctuation alarm is ringing, how to attend to it, we were knowing initially. But again, when like the healthcare professional or a team will be available during the working hours. If it happens in off hours and all, it was very difficult for us, because only security will be available and they won't be knowing how exactly. So we have made a standard operating procedure even to that, and we gave training to them, and we gave the numbers of the study team to the securities, and they have to call us immediately and should inform us. So all that things we had problems, and we have like settled like this. Then we had even some kind of problems. What we faced is temperature fluctuation while transportation of IP to the site. It was not our problem. It may be the courier person's problem. When they came in, the vaccine we received, it may be out of the temperature. It is supposed to be in 2 to 8 degrees centigrade, but when it reached at our site, when we are seeing the log, it was 9 degrees centigrade or 8 degrees centigrade. Then we had some situations we cannot start the clinical trial. Instead, we have to send the product back to the manufacturer. We have to get another shipment, and we need to start the clinical study, or we need to get a clarity from the the sponsor whether we can go with the clinical study. So likewise, that kind of problems generally comes in case of cold chain maintenance. And again, investigational product, if it is received after working hours, how to store, how to maintain all this, again, we were having the problem. Then we have made the security being in charges and how exactly to be modified, and we will call the courier person and will identify what time it receives or person will be available. Likewise, we had some kind of problems even likewise also we faced. Then again, while doing the clinical trials, there will be an overlapping of mass immunization campaign by the government of India. So generally, when we are conducting a clinical study, we will make sure like one of the inclusion criteria would be the child or the volunteer would not have received any other vaccination within last 28 days. So then during the trial, there will be a mass immunization camp come in place, maybe a pulse polio or a measles supply likewise. So when as a date we already know the government mass immunization campaign dates are already known, or we know suppose it comes on the 3rd Sunday of January or 3rd Sunday of February. When we know some kind of date like that, we like forcefully we were delayed the clinical study or 2-3 months to incorporate this, because when there is a mass immunization campaign, we cannot say our clinical trial patients not to vaccinate because it is a government program. It mandatorily has to be taken by the entire population. So in that case, what we used to do, we will delay the start of clinical study for 1 or 2 months. So likewise, we had a few issues during the study. Then we had another problems what we faced in reporting of serious adverse event. The government regulation has clearly mentioned how to report a serious adverse event. Sir has already explained us what kind of events are called as a serious adverse event, and we have to report, we have to get it, and they will be how exactly they will be doing the causality assessment, all that he explained. So generally, when there is a serious adverse event occurrence, within 24 hours, the investigator should create an initial report, and that has to be, a copy of that has to go to the sponsor, to the chairperson of the ethical committee, and to the DCGI. Okay, 3 members it has to go. Then within the 10 days, within 10 calendar days, they have to do the further, they have to analyze the report, they have to get more and more information about it, and they have to submit to the more information need to be submitted by the investigator, again to the ethical committee, to the head of the institution, to that hospital institution, and to the DCGI. Then that they will get the information. Then within 21 calendar days, the report will be analyzed, and they will identify is it a related or non-related. The trial, the essay is related or not related. So then what happens? There will be a compensation. If it is related to the vaccine or related to the investigation product, there is a recommendation for compensation. Then it goes to the DCGI, the essay with the recommendation of compensation within 30 days of receiving the report from the ethical committee. Okay. Then within 3 months of receipt of SAE, we need to, the DCGI will give an order of compensation to the sponsor. So in our regulation, they clearly specified how much compensation to be given, like depending on the patient age, depending on the problem, depending on various parameters, how to calculate the compensation that is specifically given in our Indian regulation. So based on that, the DCGI will give an order to the sponsor for the compensation. Then within 30 days of receiving the order from DCGI, the sponsor has to give the compensation to the patient or its relative. This is the problem. So when we are having a serious adverse event, so we have to be very careful while giving these reports. So we have to strictly follow the timelines, and we have to give to the ethical committee, DCGI. So that kind of, it is an extra work for us to look into these things. Excuse me. Sorry. And we even faced some kind of challenges during this pandemic, like in our lockdown period. There were many protocol deviations for already existing clinical trial. because due to lockdown, even the patients or the study team couldn't come to the hospital. The study related procedures, they couldn't complete due to the travel restrictions which was imposed during the lockdown. Then once the lockdown is over, Again, the study participants were unwilling. They were very scared to come out of the house, and they did not want to come to the hospital for any kind of sample collection or follow-up procedures. So whenever we had the sample collection problem, we created a facility where our phlebotomist can visit the patient's home to collect the blood samples. Not the sponsor has given that provision to us, and some patients agreed for it, and some patient did not even agree for that. Like somebody, an extra person coming to their home, and they may be infected. They had so much of fear for that kind of thing. So likewise, we had so many different protocol deviations occur during the clinical study. Then again, after during the lockdown, or after when we had the unlock sessions, we actually needed some kind of permission from the ethical committee to start a clinical trial or to restart the studies, which was actually in stagnant from the ethical committee. So that was also one of the problem. And after we came back, we couldn't start the clinical study for some period of time. We have to submit to the ethical committee, and the ethical committee has to have a meeting. And likewise, we delayed again for a few days. And again, previously we were giving the travel allowance to the patients, but we were supposed to give additional travel allowance because there was no public transport system available. So they have to come by taking a specialized taxi or something. Then again, we have to reimburse that kind of thing. So likewise, we had some kind of challenges. And when the patient comes here, the sponsor would not have released the money. So likewise, we had some kind of issues related to it. Then in the hospital and the immunization center, we have made some modifications to segregate the immunization center. Initially, it was an open platform. Now we have segregated it. We said if the patient is coming for the vaccination, they have to directly enter through this way. Otherwise, they have to go back to the other area. And even the vaccinated population and non-vaccinated is actually segregated. And even this area has made separated for the post-observation of vaccine. So likewise, we have made some kind of modifications in the immunization center also during the pandemic to avoid any kind of problems. And coming to the conclusion, we are doing all these very carefully, the efficacy and safety during the clinical trial and as well as post-marketing, because the general population is having a very low tolerance on vaccines. But they will be accepting the drug-related adverse events very well, because when they are developing a disease, they know that to cure the disease, they need to take a drug, and they will accept some kind of adverse events. So we can take up the example of cancer treatment. Everybody know that if you receive a anti-cancer medications, definitely they will get a very significant adverse events, but they are ready to adjust with the adverse events what is happening in the cancer chemotherapy. But again, the vaccines are generally given to a very healthy population, generally children. So people are expecting more or much more about vaccines. And again, it is another reason for low public tolerance is that the vaccines are generally mandated by the government. Suppose it is mandatory vaccines, compulsorily you have to give. Or there are some schools to get, if you want to get an admission in the school, you need to produce the vaccination card. So it is not actually, drugs are not like that. It is actually advocated or mandated by the government. So general population is always having some kind of hesitancy for the vaccine, or they expect a very good safety profile with a vaccine and compared to the drugs. So because of that reason, our National Regulatory Authority, they will ensure rigorous quality, safety and effectiveness testing for vaccines, especially compared to the drugs. So before introduced into the market, they will undergo a very strict clinical trial, very strict DCGI review for getting an approval. So once it is introduced in the market, there will be an active vaccine safety surveillance, or there will be very stringent surveillance programs implemented, and they will thoroughly reviewing the serious adverse event. They try to identify the serious adverse event. And as per the government, once the serious adverse event is occurred, within 100 days, they will finish the causality assessment, and all that thing is there. And again, so because of all these, NRI monitor and investigate AFI and ensure the safety of population. So it is all our responsibility to report anything which happens to the serious adverse event. So thank you. I don't know, I have exceeded the timing, but still thank you for giving me an opportunity to address all of you. Thank you all.
Thank you, sir.
Wonderful, a very good presentation, and it's a very lucid explanation of what the process is. I'm very happy that you have found time to do this presentation. Would you like to
sir.
take any questions for the next 5 minutes?
Yes, we will discuss, sir, if there is any questions.
Yeah, those of you who want to ask any questions may kindly type them out in the chat box. We don't have enough time to unmute you.
సార్ ఈశ్వర్ రెడ్డి గారు కూడా ఉన్నారు కాబట్టి
Yeah, anybody would like to ask any question either to
Sebastian madam,
yeah,
Juni madam or
Junie,
Ishwar Reddy.
Sebastian or Mr. Ishwar Reddy, kindly type them out in the chat box.
ప్యానెల్ మెంబర్ గా ఉన్నారు కదా సార్, వాళ్ళు ఆల్రెడీ అన్మ్యూట్ చేసుకుని దే కెన్ ఆస్క్ దేర్ క్వశ్చన్స్.
Yeah, any of the doctors? I think they're all hungry.
Possibly, sir. I think I have made them sit for a little longer.
No, that's okay. I mean,
there are no major many questions, sir. And I mean, I had seen the chat box.
Yeah.
Not many, not a question kind.
Only
that's right.
1 or 2 are there, sir. Vanishree madam is asking those 2 companies applied for emergency permission.
Yeah, I've already typed out the answer, which is on the basis of what Mr. Ishwar Reddy has said.
Yes, sir. It is emergency only, sir. It is not regular. The clinical trial reports are not ready yet.
Right.
Still, the study is not over. Both the companies had applied for emergency permission only.
Yeah, Karthika, I think you can convey your vote of thanks and make any announcements.
Excuse me, sir.
Yeah, please.
Myself,
Kindly introduce yourself, sir, and then
Dr. Avinash, sir.
Yeah, Dr. Avinash. Yeah, kindly go ahead.
Sir, the presentations by Ishwar Reddy sir and Junie madam are very beautiful, sir. Very easily understandable things, sir. And they have given a lot of information that we ought to know at this time. One question from my side, sir. Actually, in Andhra Pradesh, we are preparing for vaccine launch. We are expecting delay of vaccine by 25th December this month, sir. Is it possible, sir? Approval hasn't been done yet. We are in the preparatory phase. We are doing all the action plan and all the preparatory measures we are being taken. Can we expect vaccine by this month, sir, or 2021?
So, Ishwar Reddy, would you like to say anything?
Dr. Avinash, this is, you are ready for 25th. That's great, but what you are going to distribute on 25th of December? I appreciate your efforts. I appreciate, making things ready for storage, distribution, making the facility, validating your freezers, make sure that how the system works, how you can control the mob, to whom you should give the vaccine priority. I think this background work, you can keep things ready. Probably the day we approve the vaccine, I think that day only you can start the immunization. See, good thing is that we already granted the permission to the manufacturers. I stated in my presentation the commercial batches production. So they're waiting for our approval. Once we approve, at least these 2 companies, they have reasonably very good quantities are available with them. To at least take care about a reasonable good number of population, we can do vaccination in the next couple of months. But if you ask me frankly, exact date, as I said in my presentation, we have already reviewed their applications. We asked for some additional information. We are waiting for that information. As soon as we receive that additional information, we'll again re-examine, and if it is found satisfactory for us, then within 2-3 days we will approve after receiving the application and satisfactory reply.
Thank you, sir. Thank you, sir. One more thing, sir.
Yes.
One point from a such thought might have been in process, but we are preparing to give vaccine to healthcare professionals in the first phase, sir.
Yeah.
As my opinion is, the healthcare professionals are they can easily identify any AEFI which might occur to them, minor or serious or AEFI. They can easily identify the any symptoms and or signs that occur after vaccination, sir. Submitting portal for submit found in them is made available. That might be good for further manufacturing or further making any changes in the vaccine, sir.
I think Dr. Avinash, you may be knowing central government is almost, completed the development of data center. I think those names, those who are reflecting in the data centers, they only will get a vaccine, and they are going to keep a one certificate for each and every person who is vaccinated. Even maybe tomorrow, if somebody want to travel to outside India, they need a vaccination certificate so that digitally somebody can verify whether this person is vaccinated or not. And also, as you said rightly, if somebody would like to report any adverse events, so the sufficient mechanism has been provided to report all this. I think there is a huge data system is going to be launched by the central government.
Sir, one small submission, sir. Sir, my thing in the as of now, we have been exposed or we have been trained to the CoWIN app, sir. CoWIN app and SafeVac. We are giving training on this both topics, sir. The field level, the vaccinator, if the vaccinator finds any the details into the CoWIN app, sir, which will be transmitted to SafeVac. That is
Yeah.
Sir. But my request or my submission, sir. Some person, as many are educated and all doctors will be getting the vaccine in the first phase, making provision for self-submitting by the beneficiary itself. Such provision would be helpful, sir.
Yeah, I think you may be knowing, Avinash, even Pharmacovigilance Program of India, PVPI, at Ghaziabad, there is one organization, Indian Pharmacopeal Commission, and they have developed a even app. They even in this app, anybody can submit any SAE or adverse events, reactions, and also there is a AEFI mechanism also in place. I think your suggestion is good suggestion. I think this is the software is already available. Systems are in place. I think we will share the details with you.
Popularized, sir. This must be popularized, and this
Yeah.
the information
That's a
regarding
good
this
idea.
must be mentioned on vaccination, sir, so that it will be
Yeah.
progress in a
That's
better way.
that's true.
Thank you.
Yeah. Thank you.
See, question in chat box: which vaccine appears to be more effective? Mr. Abdul is asking.
So I think which vaccine is more effective until unless we will evaluate the data, until unless we will see the complete clinical trial data, then only we can able to say which vaccine is effective. But as on date, whatever the claims are made, these are the claims by the manufacturer at their end, whatever they have. But if you see the regulator, especially until unless we consider, we approve, then only we can, make some judgment that efficacy. At present, USFDA, whatever they have given the emergency authorization, they are claiming this Pfizer vaccine, messenger RNA vaccine, it is almost 92% efficacy. Yes.
What are the
There is a
main
question relating to the reduction of cases in India and USA. I think that's perhaps not part of this. I think we should probably be asking some epidemiologists, not in this. Yeah. Okay. Please propose the vote of thanks.
sir. Thank you so much, sir. Iswari Garu and Juni Madam with